common problem. Why didn't you guys go? No. It's all right. Okay. Now, I've been asked to speak about an update on functional bowel disorders. That's very difficult to talk about because we don't have much of an update on this. Next slide, please. Oh, sorry, do I have something here? This way. Okay, sorry. I prefer to call it disorders rather than a disease. And what I'm going to concentrate on is because these are the important parts: making a positive diagnosis, explaining major symptoms of functional gastrointestinal disorders, and looking for pointers to organic disease. The only area where you'll find some amount of update on is whether it is truly a functional disorder. By the word functional, I mean there is no biochemical, pathological change in the intestine, and it seems to be starting from an effect of the brain affecting the intestine. Why do you call it a disorder? Because it's a heterogeneous disorder. You have all sorts of symptoms: burping, belching, discomfort, etc. There's no defined pathogenic mechanism, no defined pathology. Therefore, it's clearly not a disease process. Now, this is a slide where they've actually tried to look at countries with a high incidence of functional disorders and low. And I think it's a very erroneous slide, because this particular part of the subcontinent, our enemies, have a very, very high incidence of IBS, while in India we are relatively free of it. So I don't think this is a very good slide. It's because there are no clear diagnostic criteria. Population studies are not the same as hospital statistics. There are cultural factors. If any of you have watched Pico I think, where Amitabh Bachchan, in his true Bengali fashion, discusses the size of his stool and what it looks like, you'll understand that there are cultural factors that decide why people from West Bengal come down south to have their gas attended to. Now, I know it's hilarious, but for the people who suffer. But there are no major reasons for epidemiological studies because this is a benign disease. Sorry. But let me give you a size of the problem. In a gastroenterology outpatient, about 1,200 out of 2,000 patients will come with functional bowel disorders. Years ago, long before endoscopy came in, Dr. Pulmud published a paper about how frequently people come with pure psychogenic disease. He said 1/3 of them had pure psychogenic disease, and another third of them had disease. This is in a general OPD. So you can see that the size of the problem is rather large. Now, we have something that's come up from the West. It's called the Rome criteria. They have put a label and said, unless these criteria are fit in, you have to diagnose the condition based on this criteria. Because the symptomology is vague, they have classified on the basis of symptoms. So you have irritable bowel syndrome due to diarrhea, which is called IBS-D, and that which is associated with constipation, which is called IBS-C. This has compounded the problems of research and management. The reason why I say in research, because if you want to send a publication, you say, I made a diagnosis of irritable bowel syndrome in this patient based on Rome criteria. And it is not uniform across the world. And again, this was decided by a group called the Rome Group. And if you look at the way they made these multiple symptoms and said, okay, if you've got esophageal disorders, you can have chest pain, you can have heartburn. They may all belong to the same disease, but they've clogged it under different headings without any basis at all. Irritable bowel syndrome, if you were to ask me for a sensible proportion of patients, I'd probably give you a large proportion come with irritable bowel syndrome, which everybody recognizes. Functional dyspepsia, when you don't have large bowel problems, but you still have dyspepsia. Functional pain, and I know of at least 2 instances, one of a very interesting case of a member of staff of CMC, a very intelligent person who was going through the death of her father. She presented one day with very severe abdominal pain and was crying. And her husband brought her over and we did an endoscopy, and the endoscopy was negative. And she said, yes, this must be irritable bowel syndrome. So it just took a discussion about what she was going through. Her father had just passed away and she had complications with other relatives in the family. And just a discussion with her, and I know her for many years, and now she says she's never had these symptoms again. So it tells you 2 things, that you can get functional pain. You have functional vomiting. Women who vomit, or most often women who vomit most appropriately, they never vomit on the table or on the floor, they always find a place to go. But more significantly, nausea, and then anorectal functional abnormalities. Rome's they have, the other thing about Rome criteria is, we know that there is a big connection with the brain, but they don't talk about the stress symptoms in their criteria. There's symptoms of the what I call the stress symptoms. They only talk about the physical symptoms. So that's another problem with Rome. For instance, for irritable bowel syndrome, they give us a series of symptoms which are really very minor and could easily pass off for anything. So the Rome criteria is really quite... So my rule for good clinical management, dump Rome criteria. I have a quote from Martin Luther which says, if there is hell, then Rome is built over it. So you agree with me about that. So don't use the Rome criteria for good clinical management. Now I'm going to speak on functional bowel disorders. It's partially supported by evidence-based medicine. Because the numbers, there's a big placebo response in this group of disease. You cannot get good evidence from it. But it's the management of good clinical practice has a lot of good effect. The first thing is, how do you make a positive diagnosis? How do you say this is most likely to be a functional bowel disorder? The first is a clinical history. They have to be chronic, and the symptoms have to be recurrent. Now, according to the Rome criteria, it just needs 1 day, but I think that at least 2 or 3 days a week are required before you say that this is functional. The third is the evidence of stress-related symptoms. And I'll tell you what stress-related symptoms are. If a patient comes with bowel problems and you think this may be functional bowel disorder, please ask these questions about stress. Do they sleep well? Do they wake up early? If they sleep well, do they wake up feeling tired? Do they have troublesome or vivid dreams? I once had a patient who said, yes, I see myself falling out of a plane. A lot of patients say, I see my dead relatives coming back to life. Some of them talk about serpents. So troublesome or vivid dreams are another indication. Increased irritability. If you find another member of the family, say, do you find that they get irritable over small things? That's another indication. And then they often talk of lacking energy. I don't. So please ask for stress-related symptoms if you have a patient which you suspect having functional bowel disorders. Now, in migraine, a colleague of mine has actually shown that you do have disturbed sleep, or if the sleep is good, feel tired on waking up in patients with migraine. So these are shared stress symptoms with migraine. The other pointers to functional gastrointestinal disorders are poorly focused symptoms. If you find multiple system involvement, you have a patient who's got bowel symptoms, has back pain, headache, then you can say this is poorly focused. Poorly localized symptoms, if you find a person keeps burping and also having bowel disturbances, then you're probably dealing with that. And if you find tenderness in the lie of the large intestine, that's another important thing. The last point is important, normal anal contraction. Now, some people have this condition which can be treated by themselves. When you ask them to contract the anus, they actually relax it. And when you ask them to relax the anus, like when they're passing stools, they actually contract. It's easily detectable when you do a rectal examination and easily self-taught. We don't have any sophisticated method using computers as they have in the West, but you can easily teach these patients to produce a normal anal contraction. So you need to do a rectal examination and ensure that there's normal anal contraction. The other evidence of functional bowel diseases, there should be no clinical evidence of disease, no investigational evidence of nutritional failure, symptoms that are not disabling. If you find, this I think is quite important, if you find the patient has had to go to hospital because the pain was so severe, or if you found that the patient had associated vomiting because of the pain, then do not consider functional bowel disorder. Think of an organic disease. The second thing is the stooling pattern. In functional bowel disorder, they tend to have a stooling pattern. Morning, they have about 3 stools. Second, in the afternoon, they have 1 stool. And by the evening, things settle down. So these are other pieces of evidence of functional bowel disorders. These are weak indicators. If you suspect this, please ask them about how they arrange their tables, how they arrange their clothes in the cupboard, because an obsessive compulsive personality seems to be part of a functional bowel disorder. And you can understand that. When you have an obsessive compulsive personality, when you have a pain, your mind is always wondering, what is that pain due to? I once had this student from an engineering college who said that he used to hang his shirt so the largest was on one side and the smallest was on the other. And it upset him very much if that order was rearranged. So if you have a person who has an obsessive compulsive personality, not a disorder, not the person who goes and washes his hands frequently, but a personality who wants everything in order, you're probably dealing with functional bowel disease. If you have a family history, that's another indication of functional bowel disorder. Now, each of these symptoms that patients suffer from has an explanation. It's not as if they have no explanation. When patients complain of pain or discomfort, it's usually due to bowel spasm. The reason is very often it responds to antispasmodics. If you have bloating, it's due to a hypersensitive bowel. Now, a student of mine, Ganesh Pai, and I tested this out. We put a balloon into the rectum of people who had frequent stools, and we expanded it slowly with fluid. And we found that the volumes that they experienced the desire to pass stool was higher in those who had frequent stools. So they do have a hypersensitive bowel. It's the same thing as other people have found with those who burp. People who have a functional bowel disorder, they cannot contain much air in their stomach. In fact, very often, the amount of flatus that people have, people come and tell you, I'm passing a lot of flatus. And I say, it's not that you have more flatus than I have or other people have, but that your bowel is more sensitive. So a hypersensitive bowel seems to be part and parcel of this. Frequent stools. Now again, Ganesh Pai and I looked at what is commonly called diarrhea. We collected the stools of people who have an irritable bowel with so-called diarrhea, and we collected normal stools, and we made them to there was a method of estimating the fluid content, and we found the fluid content was same in normal people and patients with irritable bowel. So it's not actually diarrhea, it's hyperfecation. They keep passing stools frequently, but the volume of fluid in it is not there. Constipation, again, is due to bowel spasm. So it's usually a situation that the pathogenic mechanism is a hypersensitive bowel and bowel spasm. How do you exclude organic disease? These are the things that we mostly worry about. When a person has upper GI symptoms, we worry about carcinoma stomach. When a person has constipation, we think of carcinoma in the distal colon. When you have abdominal pain, you think of chronic pancreatitis or intestinal obstruction. And frequent stools, you always have a worry about whether you're dealing with inflammatory bowel disease or tuberculosis. But in most situations, you really don't need to worry about these situations if you're careful in your blood tests. When would you worry is when you have a weight loss of more than 5%. People with functional bowel disorders tend to eat less, so a 5% loss is all right. If a person has fever, clearly he has an organic disease. Symptoms that rouse a person from sleep. If a person says, I'm never roused up from sleep because of a bowel movement, it weighs heavily in favor of functional bowel disease. When a person says that I've been well till now, but I'm about 60 years, and recently I have had a change in bowel, then you have to think of an organic disease. If you have a family history of GI cancer, or you have excessive bleeding in the lower GI tract, consider the possibility of an organic disease. There are clinical pointers to organic disease. If you have overt anemia or hyperproteinemia, lumps and lymph nodes, and if your findings on rectal examination is uncertain, then consider the possibility of doing further tests. I put muscle wasting here because many people, you say, okay, his muscles are not wasted, but you put them through the small test of getting up from the squatting position, or ask them to walk through a room, and if you find that they're tottering too much, then I think you need to think in terms of an organic disease. The investigation points are important. Iron deficiency anemia, I put it right at the top. I once remember seeing a gentleman, non-vegetarian. He was from Kerala, eating a lot of meat. His symptoms sounded like he had irritable bowel. He had the situation, he was very unhappy with his relationship with his children, but his hemoglobin was 6% and it was microcytic anemia. So clearly we were dealing with an organic disease. We did a CT scan and sure enough, he had a cecal tumor. So iron deficiency anemia is a good one. Always ask for a peripheral smear, because if you see megaloblastic anemia, you may be actually dealing with tropical sprue. If you see microcytic anemia, it is possible that you may be dealing with celiac disease in those in India from the north. In the south, celiac disease is very rare, but in the north, it's still present because, as you know, they have the ancestral North Indian gene, which makes it. If you find hypoproteinemia or another abnormality in the liver profile, and when I say another abnormality, if you find hypoproteinemia, think of protein lost somewhere. But if you have an elevated globulin, you need to follow it. If you have an elevated alkaline phosphatase, you need to follow it, because these may indicate autoimmune processes. The ESR and CARP is generally advised, but I'm not sure if it helps. Fecal calprotectin has been useful in separating out inflammatory bowel disease, but the test is so expensive, one rarely uses it. When a person complains of pain that goes to the back, I often do, just to keep, for my conscience, I keep testing for amylase and lipase, but I don't find the fecal elastase a useful test at all. Now, this is the only area where there's something which is an update, and we have always associated this as these are psychogenic diseases, and the association with depression and anxiety, responsiveness to antidepressant therapy and psychotherapy has supported this. But now, and I'm giving you this reference here because I want, if anybody wants to look at any of these causes, it's worth looking at. There's certainly a genetic cause for functional bowel disease. They found that twins separated at birth, both of them tend to have the same amount of irritable bowel. There is a suggestion that diet, wheat, without being celiac disease, produces an allergy, but none of these, infection, low-grade mucosal inflammation, disordered bile acid, and microbiota, all of these, but there's no clear evidence the bowel is affected, and that is the beginning of this. What this group has been pushing forward is saying the brain is only secondarily affected, but the evidence is far from clear. Now, this is about management, and this is where most people fail, most doctors fail. If you're handling a patient with functional bowel disease, the cornerstone of your management is a good physician-patient relationship. This is clearly very important. It is necessary to talk to patients and not talk to their relatives. Very often a husband will intrude and tell you, oh, my wife has this, wife has this. Talk to the patient and find out what exactly is happening. One needs to actively listen and reassure the person that you're actively listening, in the sense that if you say the person has said something like, this happens every morning. Yes, you said that this was happening every morning. You need to reassure them. You need to make eye contact, because it's no use looking at a computer or looking away and listening to the patient. Touch. This has been actually shown in studies in the New England Journal of Medicine, that just by holding hands, patients are relieved and leave hospitals further. So there's a role of touch. A complete physical examination. Very often people wave these patients off because it's a benign disease and say, there's nothing harming you, and they don't actually do a complete physical examination. Allowing patients to weep. I once had a patient who was very weepy about his condition, and I sent some medical students to interview him, and they just couldn't handle his weepiness. As soon as he started weeping, they put out their hands and said, the next one is important. Help them to accept their symptoms rather than curing their symptoms. The difference is important. When you tell them you'll have this pain, but it's nothing to worry about, and when their worries about it disappear, you help them. It's good to involve a close relative, a spouse, or a family member. And the last one is quite important because you might miss organic disease. So please keep in touch with these patients for at least 6 months. Now, do you need to give them drugs? My present principle is as few drugs as possible. Frequent stools, do you give loperamide? I tell them not to worry about stools that they have which doesn't interfere with them. But if they're going on the journey and they say, I worry about getting to a bus because I might have a bowel movement on the way, give them a loperamide just to keep them stable for that period. Pain, a lot of people use antispasmodics, but in actual fact, you cannot give it for very long. One of the best drugs for stool dissatisfaction, they don't feel happy with their stools, they don't feel that it's completely evacuated, is to use isabgol husk. It's a water-soluble fiber, and it helps to keep them under control and helps them to feel satisfied with it. People have suggested secretory drugs for constipation, but I haven't ever used it. A lot of people have actually started using antibiotics for them, rifaximin or metronidazole, and the small studies have actually shown that it helps them. But I don't know if it is really necessary. There are studies done with probiotics, but the quality of the studies are very poor. Antidepressants, because people complain of sleep disturbances, we've used low-dose amitriptyline. In fact, we conducted a study here, and they've done a meta-analysis, and they found that it's useful. For the restfulness and the pain relief that comes with low-dose amitriptyline, we give that. There's very little evidence that you need to give any dietary. In fact, they get so focused on the dietary regimen that they forget about doing it. So we really have no evidence for diet. So the only drugs that I would really use here are low-dose antidepressants and ispagola. Psychotherapy. This is something that most doctors are not taught about. When you go to Britain, their form of psychotherapy is just listening to the patient. But intervening with suggestions is also a good idea. Inquire about reasons for anxiety. You've got this pain here. Are you worried about cancer? Yes. I'm always worried about cancer because my friend so-and-so had this cancer. Or everybody around me says, you had this stomach pain for so long, it probably is cancer. Conflict resolution. Many people have conflicts in their family which actually cause this. A classic example is somebody whom actually Epen knows. Many years ago, this boy came to CMC. He's had 2 operations in 2 of the best GI centers in Kerala. One time they took out his appendix, the other time I think they took out his gallbladder. He came here and we did our investigation. We said, we're not finding anything wrong. So I said, is there something troubling you? And he said, no. His uncle came and told me, this is purely anecdotal, but his uncle came and told me his father had deserted his mother and gone away with another woman. So I went to the boy and told him, I just advised him, I said, why don't you write a letter to your father saying, I'm unhappy about what you've done, but I love you and I forgive you. Now, I didn't know what happened to him because he went out. I let him, I didn't follow up. But 20 years later, at my retirement, Eben, who lives in the same vicinity, says he's never had to go and have another surgery again. This is purely anecdotal, but conflict resolution, I find conflicts very frequently among patients with functional bowel disorders. You talk to them, are you having any problems? It's either a problem with a mother-in-law or a problem with a spouse or problem with neighbors, and or problem with workmates. I have people who come in from Auroville and they say, I work in that office and I can't get on with that guy because he's always insisting on his way. So conflict resolution is important. Now you might find this funny, spiritual resources. I'm going to illustrate this again with an example. There was a Muslim who came to me and said he had these symptoms, and I said, see, your blood tests are normal. I think this is more psychological. I asked him about things that were causing him anxiety. He said, yes, my business is causing anxiety. So I asked him, how many times do you say namaz? He said, I say it 5 times. I said, when you're saying namaz, do you think about the words or do you have other thoughts? So he said, I'm often thinking about my business. So I said, start concentrating on the words. Again, this is anecdotal. I went down. I'd forgotten about him. He joined the crowds who I don't see again. And about 4 to 6 months later, when I was walking in the campus, I was accosted by this lady with a hijab, and she said, don't you remember me, doctor? So I said, I don't. So then her husband joined. He said, that made a big change in my life. So in people who are truly religiously minded, I try to encourage them to look at their spiritual resources. The next is engaging in meaningful activity. People who go out and live lives, I'll give you examples from 2 extremes. One is the senior people who are retired from their work, they don't have anything to do. It's to get them involved in meaningful activity. The other is, the new slaves of the generation, the IT professionals. They have to work from 7 a.m. to 7 p.m. or later, 9 p.m. They have these things to hit. So I say, try and find something that you do outside this, outside your workplace, finding meaningful activity either in photography. And the final thing is a self-reassurance. You should tell yourself that there's really nothing wrong with me. So I often tell people to give a 3-month trial of drug-free therapy. What do? I ask them to do regular exercises, walking. It increases endorphins. As I said, conflict resolution. Tell daughters-in-law to make coffee for their mothers-in-law and sit and chat with them for half an hour. Spiritual exercises, as I said, read up things that self-reassurance. This line of therapy is actually good for both doctors and patients because the doctor stops thinking in terms of drugs, and patients learn to handle this by themselves. I think that's the last slide. Thank you.
We have time for one question.
Have I used up my time?
Okay, thank you, sir. We will have a 15-minute break for tea now.
I thought AJ Joseph is supposed to speak, isn't he? Is he okay? Sorry? Yeah.
Fantastic talk, sir.
Come on. Everybody's...
No, sir. This is what we really need to hear. Thank you. Thank you for accepting our invitation.
Welcome. I'm getting to be the... Sorry.
We'll ask you the questions during tea time.